you for joining us for this evening's session. We look forward to a very interactive and informative session. Please check the chat for the CME sign-up form. And yeah, feel free to ask questions in the chat. Dr. Bola and Dr. Kumar will be managing and answering any questions you may have. So have fun.
Thank you,
I now hand you over to Dr. Kumar, who would be our moderator.
Thank you very much, Amara. And good evening and welcome to all of you all. It's nice to see so many new people on the virtual world. And for the people we know, welcome again for more learning. So this evening is our first meeting for trainee doctors or to anybody who wishes to participate in this program. This is part of our series of education programs that we have put together. So we will have a few cases that we're going to be discussing today on our refractive surgery discussions. And we have our in-house optometrists, namely Renel and Ibrahim, going to present these cases. And these cases are largely from the books of Dr. Bola. So I will facilitate some of the questions and he will be giving us answers. Feel free to ask your questions on the chat. That would allow me to look into the questions and bring it to the forum. So enjoy the session and a lot of learning to do. So on that note, I will bring in Renal. Renal, you share your screen.
Okay.
Yeah, as you brought her in there, Vin, one of the things I want to say is, before Renel gets going, as she opens her screen and stuff, is that when I saw Renel present it at one of the meetings, I realized it would be a nice one for us to share with the doctors, because it really highlights a few of the challenges we have when we do biometry. And biometry is a really common thing that we have to do on a day-to-day basis or a week-to-week basis. And sometimes we get a surprise, and when we get one, we have to know how to deal with it. What are some of the challenges and how to investigate. And that's why I thought we should bring it back. It's such an important thing. And I want to thank Renel for taking the effort and time to do this talk a third time for us. Renel has been a key member now of the team for over a year with us and has really shown us a lot in terms of how we should link our optometric services with our ophthalmology services. And she's brought a lot of positivity into the development of the refractive type work that we're doing. And she's always keen to develop. Yeah. So thank you, Renel, and the floor is yours.
Thank you. Right. So today I have 3 cases that I'm going to present.
Renel, probably just do the refractive one.
The first one?
Yeah.
Okay.
And then we'll do Ibrahim's too, and then see what happens next.
No problem. So this case is called a surprising outcome. We had a 55-year-old female who was referred to us from her optometrist for right eye posterior capsule opacification and a left eye macular lesion. She had a history of right cataract surgery and right macular hole repair in 2016, but no significant medical history or family history. Her presenting VA, the first time we saw her, was 20/50-3 unaided, 20/50 aided, and a pinhole of 20/50. On the left eye was 2400 unaided and aided 20/80 with the same pinhole. The pressures were 16 in both eyes. On anterior segment findings, everything looked fine except that she had a bit of PCO on the IOL in the right eye and NS2+ cataract in the left eye. So these are some of the clinical findings in the posterior segment. The top scan shows the right eye, and as we said, she had a macular hole surgery for that eye. So you can see the repaired macular hole with the purple arrow here. And in the left eye, at the bottom, the blue arrow shows a partial vitreous detachment, epiretinal membrane, and a lamellar macular hole with intraretinal cysts. Our diagnosis and plan: the diagnosis for the right eye was pseudophakia, mild PCO, and a closed macular hole. And for the left eye, NS2 plus cataract, a PVD, epiretinal membrane, and a lamellar macular hole. Our plan at this point was to do right YAG capsulotomy for the PCO, then left cataract surgery, and left vitrectomy, ILM peel, and ERM peel. So one of the first things that we did in pre-op was the biometry, and we did it using a scan. From this, initially looking at the figures, you can see that the K values were pretty similar in both eyes. There wasn't a large difference between them. Same with the axial length. So everything from this, it seemed to be a good biometry report. And so we went ahead and made an Iol selection of 22.5 diopter lens, which would have given us an estimated refractive outcome of minus 0.34. So some of the pre-op details. As we mentioned before, from pre-op, biometry showed no major concerns. We usually check to make sure that we have the correct patient name, correct date of birth, and no significant difference in the axial length and K values between both eyes, which all of which we had. So we went on and proceeded to do the surgery. The surgery was done, and initially we wanted to use a single piece 22.5 diopter lens, but during surgery there was a tear in the posterior capsule, so we used a three-piece Iol instead, and it was placed in the sulcus. To compensate, one diopter was taken off the power, so a plus 21.5 diopter lens was used with the same A constant. At the first post-op, the VAs for the right eye was 20/30 unaided, and this was post-YAG, and aided 20/25, and then the left eye was counting fingers unaided and aided, but the eye was healing well post-surgery, and there were no complications of note, and the IOL was in place. On second post-op, again, the unaided and aided VAs for the right eye were the same, and the same for the left eye. It was counting fingers in the left eye, and the same counting fingers aided in the left eye as well. And everything with the eye itself looked fine. The IOL was in place, the macula and the retina was flat, so there were no complications. The third post-op now, we still had no improvement in the left eye VA. It was still counting fingers. However, everything else looked fine. So at this point, we were a bit concerned about, why the patient was still counting fingers at the third post-op, and a refraction and report was recommended. So when we did the refraction right off the bat, you could actually see, circled by the green arrow, we got an auto-refraction in the right eye of minus 8.75 with a minus 1.75 still, and a refraction of minus 9.5 with a minus 1.75 still. So we had a large myopic refractive outcome. The right eye was minus 0.50, minus 0.75 at 2, and that gave us 20/20 in that eye. So now we had this huge myopic refractive outcome, and we had to figure out what to do next. So we were surprised by this outcome because, as you would recall, we expected like a small myopic prescription. So now we had to go back and investigate the reason for this. So at this point, our diagnosis was a left post-operative refractive surprise, and we plan to do a critical incident report analysis to, one, identify the problem, and to determine the best solution for the problem. So step one was to find the cause of the problem. We had to rule out that there was any surgical or pathological cause. This just shows up a pre and post-op OCT scan following the ILM and ERM peel. And as you can see, the bottom picture was the pre-op scan where you could see all the changes there, and the top picture is the post-op scan where you can see the retina healing nicely after the surgery. And again, this is a further post-op scan where you actually see the retina healing even more. So we knew that it wasn't a problem with the retina. We also did a thorough assessment of the ocular health, and we found that, well, the cataract surgery and the triple P were well done. There were no post-op complications. The eye was healing nicely. There were no tight corneal sutures, no IOL subluxation or dislocation. Although the IOL was placed in the sulcus, it remained fixed and in place, and the retina was healing nicely post-surgery. So now that we ruled out that it was any sort of surgical complication, we went on to do a corneal topography. The corneal topography looked fine, so it told us that the patient didn't have any abnormalities or ectasia. We then went on to review the original biometry. So this was the biometry I showed before, and here highlighted in blue, you could see an axial length for the left eye of 22.46 millimeters, from which we decided to use a 22.5 diopter lens. And again, by reviewing the biometry, we checked the right and the left, and we realized, okay, this was a good biometry report. There was no big difference in the values. It had the correct patient name, date of birth, and everything. We then went on to repeat the biometry. So in this case, we used the optical biometer, and we actually got an axial length of 25.95 millimeters. So there was a large difference in axial length when we redid the biometry. So the original axial length measurement from the first measurement was 22.46 millimeters, and the repeat axial length measurements was 25.95. So that was a difference of 3.49 millimeters in axial length, and for every 0.33 millimeters measurement error in axial length, there's approximately 1 diopter post-op refractive error. As a result, underestimating the axial length by 3.49 millimeters would produce a refractive error of approximately minus 10.5 diopters, which is approximately what we were getting for the spherical equivalent in this case. So what went wrong? So we realized that the wrong IOL power was placed as a result of the wrong biometry values. We believe, we're not entirely sure, but we believe that the patient's name and information was probably entered into the system, but measurements were probably taken for a different patient, assuming it was the patient entered, and the data was printed and given to the doctor to review. So this is a little bit about the biometry process. So first, the patient data is entered by the tech who's performing the biometry. They put the patient name, date of birth, and whether the patient is phakic or pseudo-phakic. The patient is then seated and the measurements are taken. A range of IOL powers and expected refractive outcomes are calculated, and a report is formulated. The report is then given to the doctor, who looks to ensure that the reports look fine and there's no large difference between the eyes. And once the report looks okay, the doctor then proceeds to select an IOL power that will give the desired refractive outcome. And the biometry record with the selected IOL power is then uploaded to the patient's file from which the data is pulled for surgery. So we believe that the error occurred somewhere between steps 1 and 2. So we had the wrong biometry values, but the correct patient name and date of birth. So how could we have known? So again, we had the correct patient, the name, date of birth, and the biometry report looked accurate. However, we didn't have the IOL power that the patient used in the previous surgery. We didn't have the lensometry, and we didn't have the refractive history. So the second step was to come up with a plan to fix the problem. And so there are a couple of treatment options. Dr. Bola, would you like to talk a little bit more about it?
Yeah, sure, Renel. Before I answer this question, this is such a wonderful case. I want to just mention about the patient and how it felt when I was told this case was in the clinic. So I was in the clinic. I didn't know that we had this issue, and then somebody just came and told me that the patient had surgery and really not seeing, and it's about 3 weeks now. So I just looked at the notes and I thought, well, I don't know what happened here. I mean, everything looked okay. Had a straightforward surgery and seeing count fingers. So I'm not sure if they're just making a mistake with checking the vision. So I told the patient to come in. I had a look at the eye and I couldn't see anything wrong. So I didn't know what to do now. So I just said, well, let's do an OCT. Maybe it's some macular edema or something like that. So I sent the patient for OCT. Patient comes back, OCT looking good. I look at the optic nerve thinking, well, maybe something wrong with the nerve, but the nerve looked fine. So then what I did was I just do an auto refraction, just thinking, well, I don't know what's wrong. And then when that came back, we decided, let's get a proper refraction because now I know what is the issue, Now, the key thing in this was I was looking at this lady, she looking at me, and she looked petrified. She looked like, well, why can't I see? And everybody's saying everything's okay. So I think one of the things to recognize when you have this kind of problem is that you have to recognize what are the fears that the patient might have. And once you recognize that you have a patient in front of you here, you have to recognize that you have to alleviate these fears before this patient leaves the clinic. If not, they're going to go home and it's going to brew in them, and this could lead to further problems if you don't alleviate them. And what I realized was at that engagement or at that visit, she was thinking, because when I was talking to her, I could tell she was thinking, am I going to go blind? I mean, that was her first fear, is there a major complication here and am I going to go blind? So she was afraid that I had to try and alleviate that before she left the clinic. She was thinking, well, what really went wrong here? Do you all know what went wrong? Why did this happen to me? And the last thing is, could you fix it? So when I figured out it was the autorefractive was the lens, I told her, I think I know what's wrong here. Not I think, I know what's wrong here. And we could fix it. So that was the first thing I tell her. I know what's wrong here. We could fix it. So she started to feel a little more relaxed. And then I told her, you have to do two things for me. One, you have to give me time because I have to run all my test investigations and everything that I need to do to fix the problem. And I also need time for your eye to heal for me to then go back and sort it out. So she started to relax. I could tell that she was relaxing. And I also have to recognize that I needed to give her some time to kind of vent a little bit, and get herself into a better frame of mind to be able to deal with what was going to happen next. Because I needed about 2 months really to be able to get the eye to heal to a point where I was feeling comfortable. Now I know what the refraction is. I'm comfortable with the cornea being clear. I'm comfortable with the refractive outcome. And now I could decide, well, how am I going to deal with this? So that was something, Renel, I thought that was something I wanted to just highlight, in the case. When I eventually got around to it after doing all the tests, I was thinking that the treatment options would be, could we correct it without surgery? Something non-surgical. maybe Renel could correct it, and I am okay. You know, contact lens, maybe glasses as an option or something like that. So I kind of bounce it back to Renella, you know, and waiting to see what might be her thoughts. And then what are the other options? Is it taking the lens out, putting the correct lens in, or doing a piggyback or a lens on top of that lens to correct the problem is a surgical option that could be considered. So that was kind of what I was thinking, Renel.
What I would like to add to Dr. Bowler's comments out here is the fact that I think I'm presuming that all the participants have done and seen some cataract surgery. And as we're all aware, cataract surgery is one of the commonest procedures done world across. And we do the standard phacoemulsification and extracapsular cataract surgery, small incision cataract surgery. The varieties are quite obvious. But the interesting thing is, there's a process to removing the natural lens and putting an artificial lens implant. And as Dr. Bowler has just pointed out, one of the biggest things we learn is the integral process of biometry in assessing the eye. Surgery is one component, the biometry is the other component, which is as important as the surgery. The technical side is also important. So when the biometry, which Renella has pointed out, has been flagged up to be an issue out here, besides investigating a particular case, you go back and look into your system, because through your system, you do this continuously and find out what is your outcomes from your biometrics and so many other things. So one of the take-home messages from this case is not just dealing with the anxiety, as Dr. Bowler pointed out, about the fear of a patient, the anxiety within the doctor, and how do we deal with the situation, but also looking back at what goes on in the preparation for cataract surgery in a given patient. And there are so many steps and so many people involved. Remember, this is a team effort. So that's what I want to bring home, Dr. Bowler. So while we look at treatment options for this patient specifically, so any thoughts on your comments about the process of cataract surgery and why biometry is so important?
Yeah. So it's an interesting thing. You know, one of the things that struck me, and Renel was looking at it there, was the biometric process.
Correct.
You know, something that we as the clinician, we sometimes forget that all these steps take place before we see the biometry.
Correct. Yes.
You know, so it's very nice to see her graphic.
Yes.
And flow chart. And it also is amazing that she's able now to pick up where the issue is, you know, in that flow. And one of the other things that we could introduce, Renel, I was thinking that looking at that list, was to have a double biometry. That is, you have optical plus you have ultrasound biometry. So now if you had two biometries, it's very unlikely that you'll get this error going forward. And that's one of the things that we're going to introduce, right? We're going to have in both centers, both in the north and south, you're going to have optical biometry and ultrasound biometry in the future. So I think that would add to to reduce your risk, which is risk management of these cases.
Okay. Yeah, Renel, continue, please. Yeah.
Thank you. So as Dr. Bowler was saying, we considered whether we should do an IOL lens exchange, a piggyback sulcus IOL, or probably a contact lenses. And in our management plan, we discussed with the patient what had happened and why she wasn't seeing well with the left eye. We discussed the options and our plan to fix the problem. She was given time to think about it. And once she was ready, we proceeded with a left IOL exchange using a plus 12.5 diopter lens. So what was the outcome? In the first post-op, immediately you could see improvement in the visual acuity in the left eye. It was 20/40 unaided. And the AR that was done on the first post-op visit gave us minus 0.25, minus 1.25 at 17. On the second post-op visit, a refraction was done, and we got a refractive error of minus 0.75, minus 1.25, which gave her a VA of 2020, and she was really, really happy with this result. So now that we fixed the patient's problem, we decided that we should implement some measures to reduce the risk of using the wrong patient biometry again. So post-op refractive surprises, as you all know, are rare, but they are not impossible. They do happen from time to time, and when they do, it provides a good opportunity for improvement. From this case, it was important that we think about ways to reduce the risk of it happening again. And as a result, we decided to update our checklist for reviewing biometry to include the IOL power if the patient previously had cataract surgery, a more detailed refraction history, and as well as lensometry if the patient had glasses. So that was the first case.
Wonderful. Don't run away. Stay there.
Yeah.
I think I've got Dr. Dwarka along with us. I would like to join him into the conversation. Dorian, your thoughts on this case? You're aware of this case, I know. Comments about one, how do you deal with a surprise like this? Two, your comments about process of biometry and what are your thoughts going forward?
Good afternoon, everybody. So and thanks, Vinit, for inviting me to speak. I'm fortunate that we don't have very many. I think we're fortunate we don't have very many like these, and I've not personally had to deal with one. But we've had cases in different hospitals I've worked in that had similar incidents. So I was quite happy with the process thinking that Renel and the team came up with. And I felt that in retrospect, the changes that were indicated are quite important, and they will be well received. But it's always important sometimes when we have these cases that look so normal and so natural, unless we take active and then we turn out to have, let us say, incorrect name or incorrect person, unless we take active steps to include everything, then we tend to we could miss out some basic things and end up like this. So in terms of the process that we had, that's fantastic. And in terms of the ideas of putting all these things on the sheet and checking them routinely, I think this is a fantastic way forward, because in my process as well, I tend to ask for several of these, but I could easily see how this could lead to a problem. Thanks, folks. And thanks, Renel.
Yeah, Vin, I posed a question here to the audience, but I suppose I have to ask you, this is the biometry given rise to the wrong lens being selected. But it's nice for, especially in exams, I know we get asked this all the time, or it's asked, it's asked. They ask you about refractive surprise, and then they ask you, so where is it the most likely part of the process that you get the error or the problem? If you could discuss that a little bit, and how then you could reduce the risk, because that's an important thing.
Right. It's a very good question that you asked me. And I think Dorian pointed out that fortunately, we don't see much of it nowadays. Unfortunately, I have experienced this even in our unit in UK. So why this whole process of doing biometry is so very important? So there are two components, as I pointed out earlier. One is preparing a patient and one in theater. So, and Renel has pointed out about what are the various steps in doing the biometry. As a junior doctor, we used to do biometry ourselves. And so we would take care to ensure that all the details. And today, I think Priyanka is on the meeting today. She leads a team for all biometrists, which are technician-led. who are more precise and are able to do it. But it's transposing the information where one of the issues can flag up. So name, date of birth, or two people having the same names, same date of birth, biometry errors can land up. But having some double checks, such as lensometry and other things, would allow to minimize and mitigate that risk right at word go. The second place where this thing can happen is in the operating theater. The confusion sometimes that can happen in bringing out the wrong lens implant or somebody opening the wrong lens implant. So what was one of the systems that we put in place within our unit in the UK, and I see it happening out here within CVRS, is the fact that a patient will have their name written on the lens implant that would be used. It would be checked on the notes that has been identified and made sure that the biometry is counter-checked. So we went through this process, and it's a very robust process as far as possible. And as you probably pick up from this case, Ronel pointed out to us the patient's name was right, date of birth was right, but the details that was put into that biometry sheet was different. So human error can happen, but how do we overcome this problem and making our systems and checks as robust as possible? It's not impossible that this will not happen again, but we can mitigate these risks. But one is the biometry process, but I think we've addressed the other issues of the anxiety about the patient. And you rightly pointed out, Ronnie, about how do you deal with that? But also it's important for a surgeon and the doctor who leads the team and who does the surgery, who has participated in this activity, also to have some mentor whom they can talk to and reflect on what has gone on. And that's a very important process. And I would encourage everybody, particularly trainee surgeons, etc. You will go through all these kind of challenges of complications, these kind of challenges in clinic. Every surgeon who has participated in eye surgery would have gone through this. That's one thing I want to point out. Everybody, if they've not gone through it, they've not done enough surgery. That was my mentor's comment. Remember that everybody goes through every kind of complications in cataract surgery. But it's not about the complications, how you manage the complications and taking the patient in your journey and explaining to them and working with them. That's the most important part of this.
Yeah, just to add, Vin, to that safe surgery process.
Correct.
You know, that's such a key word there. And, you know, that's what they like to ask in exam, but it's also practical.
Yeah.
It's so important to know about safe surgery process. One is we've introduced this, and you've seen it. We didn't have this process about 6 months ago, where we write the name, we stick the lens on the patient's nose, and then that patient comes in the theater, and there is one lens, one surgery, one lens, one surgery. So that is a safe system that is worldwide. Yeah. One patient comes into the OR with one lens, and we do one surgery. And that really is a nice system in that you almost always sure it's that patient's lens. The other thing that we would do is when the patient comes in, we have timeout. You know, they call it the timeout. So you have one timeout where you look to see if you have the right patient. So you ask the patient, what is your name? You don't call them by name. You ask them, what is your name? They tell you their name. You know, yeah. So there are ways that you do it. That is WHO safe surgery guidelines, right? And you have to know this. So then the patient tells you their name, and then you check it on the list to make sure you have the right patient, you have the right eye that you're going to operate on, and you also now check that you have the right lens. So you get a check when the patient come in. The second time you have a timeout is just before you put the lens in. You know, you're supposed to now say, okay, let's do the check again. And your scrub nurse and the assistant runs the check again. You know, and that's a good way of preventing the wrong lens from being inserted during surgery. You know, and I like that we do the first time out all the time, but the second one we don't do all the time. But you have to know about it. It's important.
Absolutely. And taking it further from there, safe surgery is something that's recommended by WHO, and most units world across use this. And it's important for anybody giving exams to be aware of what is an audit, why it's important to do an audit, and how do you go about implementing any audit outcomes that you tend to find from processes like biometry or post-operative surprises, etc. So this case actually points out to us there are several things that are take-home messages from this case. And as Renelle has pointed out, post-operative surprises are rare, but it's important for us to understand the process and do audits. And that's something that I would recommend each one of you to look into your own units and work from there and take it forward. The more you share information, the better you become with your surgery.
Yeah, you want to get Ibrahim?
Ibrahim, while you're getting your case, thank you very much, Renelle. Thank you very much for sharing this wonderful case and all the work that you have done. And anybody, any comments while Ibrahim gets ready with his presentation, please feel free to ask your questions, so don't hesitate. This is a forum where you can ask any kind of questions. No small or big question is important for you to understand, so feel free.
Yeah, and you can also put it on the chat, and then we could just do it. We could just do a little chat on the side as the case is going on, or even after the case is over. So feel free to put it in the chat, or just unmute and chat and say what you want to do. So any questions from the audience, or anybody want to add anything before Ibrahim start? They could on that case we just did.
Right. While Ibrahim is getting ready and you're not getting ready with your questions or comments or anything else, Ibrahim, I think, Ronnie, do you want to introduce Ibrahim?
Yeah. Okay. So any comments before Ibrahim start? Anybody? I see something on the chat here. The RCO. Right. So they recommend printing out biometries. The lens power should not be handwritten in notes. Excellent comment.
Yeah.
Yeah. But just note that we had printed biometries and we still got it wrong. You know. So even that is not 100% accurate.
I think I have to add to this, Dr. Ramdas, that probably they took this out of my own mistake that I did within UK when I had written, took out information from printed biometry and wrote it on the case notes, and I had written the wrong number, and then the sequence of events led to issues. I'm just sharing my personal story about this, but yes, you're spot on about it. That is, the college recommends printing out biometries. And it's important, also what the college says is that you show up the biometries when you are starting the case, something to double check. So single check, double checks, whatever processes you all have within your systems, make sure it works robustly. That's very, very important. Thank you for the comment. Ibrahim.
Okay. Any other questions? And don't forget to unmute your mic if you want to ask anything. Sometimes you're talking to yourself and you don't know. Yeah. Okay, so no questions. Remember, if you want to ask questions, even after this case, you could still ask about the first case, So don't feel you missed an opportunity there to do so. So Ibrahim has been with us for a much longer time than Renelle. He is a pretty seasoned optometrist with us, and really has grown tremendously, not only in his area, but also with our team, and he's really added a lot of value to the whole team, to the development of our practice. So Ibrahim is doing today surgically induced astigmatism, a couple of cases on this that we've had to deal with, and it's a really exciting and interesting talk. So go ahead, Ibrahim.
Hi, good afternoon, everyone. So tonight I'll be presenting a few cases on surgically induced astigmatism. You all see in the screen, right?
Yes.
Okay. So beginning with case 1, we had a 61-year-old female patient who presented with blurred vision into the clinic after doing cataract surgery in the right eye around 4 months ago. Her main medical history: she was diagnosed with lupus. She was not diabetic nor hypertensive. The only significant ocular history she had was the cataract surgery that was done. She was currently using Refractive, wasn't under any current medication, and her only known allergies were Imuran. On preliminary testing, her unaided vision was counting fingers in the right eye with a pinhole to 0.6 or 20/70. In the left eye, her unaided vision was 20/20 or 0.0. Her pressures were within the normal range, 11 in each eye. She saw the doctor for assessment, where he diagnosed the right eye as being pseudophakic and the left eye as having an early NS-PSC+1 cataract. The diagram on the left shows a drawing of basically what was seen. We had the Ecke incision seen superiorly above the cornea, and the IOL was in the sulcus. No obvious PC tear, and the IOL looked pretty well centered. The doctor's plan at this time was to perform a refraction, a gas and OCT MAC, and review the patient in 1 month. At the 1 month review, the refraction was found to be in the right eye, -3 with a -4 SIL by 105 with a vision of 20/20. And in the left eye, -050 by -025, axis 160 with a vision of 20/20. The diagnosis by the doctor was surgically induced myopic astigmatism, or SIA for short, right pseudophakia. Both the optic nerve head and the macular OCT came back normal. This patient was then referred to a corneal specialist for corrective surgery. In around 6 months' time, the patient returned after seeing the corneal specialist. He recommended no surgery to be performed. The patient had also gotten spectacles, but wasn't adjusting well to them. Both the right and left eye looked pretty stable compared to when the doctor saw the patient the last time. The plan now was to trial extensive wear contact lenses, to perform biometry, UBM, and topography, and to consider a Sulcoflex toric ICL. So the patient was trialed with contact lenses, but was not happy with them. So we proceeded to do the different tests. The first one, the biometry. This is a picture of the biometry that we did. Everything looked pretty normal. What was significant was that in the right eye, the patient had a little more astigmatism, 2.4 diopters compared to the left eye, 1.95. The CCT was pretty normal in both eyes, as well as the axial length were close within range. The topography showed regular astigmatism against the rule. No irregular astigmatism was seen from the surgery. We also did a UBM. The UBM showed an open sulcus with enough space for a sulcus IOL. We used something called a Sulcoflex Iol Calculator. It's an IOL calculator online where it will give us a toric lens needed to correct this patient's prescription. This is just an example. It's not the exact values that we used, but this calculator, it requires the target refraction, the pre-operative refraction, the axial length, the method of the axial of the biometry, the anterior chamber depth, as well as the case and the surgical induced astigmatism. So after the doctor got all these tests done, the patient file was sent to our foreign refractive colleagues for review and discussion before proceeding with surgery. It was decided to try a right piggyback ICL. We discussed with the patient the risk of UGH syndrome with the Sulcoflex lens and risk of lens removal if complications arrived. The patient agreed to proceed. The lens we used was the Sulcoflex toric IOL implant, -9, and the surgery was done. At the first post-op visit, the visual acuity unaided was found to be 0.2 or 20/30 with a pinhole of 20/25. The doctor's assessment showed the right IOL lens was centered in the sulcus, no corneal edema was seen, and the disc and macula looked pretty normal. The plan at this time was to perform a refraction, to do a left phaco IOL when the patient was ready, and review the patient in 1 month. So the patient did not keep the refraction appointment and came in a little earlier to see the doctor, as she was having some discomfort with the right eye. When we did visions, the patient vision had dropped in the right eye to 0.6 and pinhole to 0.4. Assessment showed anterior chamber cells +2. The IOL remained well centered. The plan at this time was to treat the patient with Predfort for right post-op uveitis with corneal erosions. The patient was treated for around 6 months and then came in back for refraction. At the 6-month doctor review, the refraction was found to be +3 minus 350 by 93, with a vision of 20/20 in the right eye. In the left eye, the patient was now -3 minus 250 by 25 with a vision of 20/20. The assessment was pseudophakia with a quiet anterior chamber, and the left eye had an NS +2 and PSC +4 cataract. The patient was very happy with her unaided vision in the right eye, and she was only interested now in surgery in the left. So we decided to go ahead with a left phaco IOL. We did the left surgery, and her visions were basically in the right eye unaided 20/30 and in the left eye 20/25. We advised the patient that she may just need her reading glasses and she would return for refraction and reading glasses whenever she's ready. Right, so that was the first case. Any comments or questions?
Trying to mess around.
Yeah, sorry about that, Ibrahim. I didn't realize I was on mute.
Right, okay. Right, Ibrahim, this is a very interesting case. I would like to get more questions from the audience while I quiz our colleagues as to what was the most challenging part of this patient. So I think it was Ronnie who did the surgery on this patient, correct?
Yeah.
So Ronnie, take me through your challenges with this patient, because as I said at the outset, cataract surgery, we have grown through 3 different types of surgeries. One is intracapsular cataract surgery that we don't see anymore. And then we grew up with extracapsular cataract surgery. And then we also have small incision cataract surgery and decombinous procedure of phacoemulsification cataract surgery. So you see that a significant number of patients that we see in clinic have had extracapsular cataract surgery. So what we're looking at is out here a challenge from extracapsular cataract surgery. So do you want to talk to me about what was your initial thoughts when you saw this patient? Why did you go along the sulcoflex route? And if you look at the refraction for this patient, when I went through this case, I was intrigued to note that this patient, even with this refraction post-operative, is unaided 0.2.
Yeah.
So please explain to me how.
Yeah, this is a really interesting case. So just go back to the diagram that you did, Ibrahim. A really, really amazing presentation. You know, I really, really enjoy it. And I know you tried to put together this, this one, the Ecke incision. The Ecke incision has actually been done well. It was done superiorly on the, just on the limbus area. Okay. And I was surprised when I saw the case that it had so much astigmatism, you know, but these Ecke incisions could do you that. You know, you do a nice incision, you put the stitches, and all of a sudden, you just get this post-op refractive problem or refractive surprise, where you have this surgically induced astigmatism, and you wonder, well, why? You know, and I think I really took this case on because I've seen many cases like this where extracapsular is done, and they end up with this kind of problem, a surgically induced astigmatism. And I was thinking, well, let's see if we could solve this problem. I mean, that was my first thing, because if I could solve this one, I could probably solve a lot of the others that we keep seeing. You know, patients coming in and they're real unhappy because they're worse off having had the surgery, you know, and that's really distressing, because cataract surgery now has become refractive, where people expect to see better, you know, and this lady saw worse. So she was really unhappy when she came to the clinic. And you know, it really hurt me a bit, because I saw a nice surgical procedure and I wondered, well, we must be able to help this lady, you know, I must be able to correct this. So the first thing I thought, well, let's see if the corneal guys could do it. You know, they're going to take the keratome and they'll be able to put do RK. You know, that was my first thought. They would do RK, radial keratotomy. So I sent it to the corneal guys thinking, hey, they will solve this problem. This is an easy one. They just do RK and we good, you know. And then the patient came back and said they're not RK. So they can't solve it. So then I thought, well, if they can't solve it, we should try and solve it here, you know. So let me ask my foreign guys if they could solve it, you know. And then they told me, well, run the checks. And I decided, okay, no problem. Let's look at everything. Let's look at cornea, and just go to the topography. So the topography is very interesting too, because if you look at the top, you can see that there is some irregular change on top, that blue area up at top at 12 o'clock. But in the visual axis, where it's important, you have regular astigmatism, and therefore correctable with a toric lens, right? So this is what the guys told me here. When you see this kind of topography, we could think of correcting this with a toric IOL. So I said, well, great. And they said, but you have a problem. You have a sulcus lens. I said, well, what am I going to do? I have a sulcus lens. He said, well, you have a problem, because if you put a sulcus lens on top of sulcus lens, you run the risk of OG syndrome, right? You run the risk of this patient getting post-operatively uveal chaffing from the lens. And that's exactly what happened to us. The patient got uveitis post-op because the lens was rubbing on the iris, right? And causing uveitis or iritis. And I ended up having problems trying to post-operatively deal with that. And how we dealt with that was we kept the patient on Predford, slowly reducing it over a 6-month period. So this is one of the complications of putting these sulcoflex lenses in, or lens on top lens, piggyback on top of sulcus lens. So we knew that there was a risk. This lady was so upset, she was happy to take almost any risk. What Ibrahim didn't tell you on one of the things, because I told him to take it out, was that we actually put the lens upside down first time around. And then I had to take it out and flip it and put it back in, you know? And so it's really not an easy lens to implant to start off with, because it's huge, you know? So that was the kind of thought processes I was having and problems that I was having here. What I think is also very interesting, and you brought it up, is that this lady is almost 6'6", unaided. Yet, when you refract her, you get this huge still, which is obviously not there. You know, so when you put these lenses on top of lenses, your normal refraction is also very difficult to get accurately or right. The bottom line is the lady is 20 happy. It means we don't have to give her that sort of refractive lens implant, because she only requires spectacles for reading, and she's happy with our spectacles.
Okay. It's interesting that you spoke about quite a few things, particularly using the sulcoflex lens and the challenges of having a lens implant not in the bag, in the sulcus, and the consequences of the uveitis glaucoma hyphema syndrome, which is what we call as the UG syndrome, if people are not aware of what it is. But this case highlights a very interesting thing. One is a patient who's troubled by the issue. 2, you've got all your preparation done. And as Ronnie pointed out, is your topography tells you that the central area is pretty good. It's only the superior area where the incision was done where there is steepness and you notice that problem. And then how do you go about dealing with this kind of situation, particularly about limbal relaxing incisions is the comment that we tend to use in the refractive surgery world, because there are 2 ways to deal with this problem. One is having a permanent procedure such as the corneal refractive surgery or intraocular lens surgery. So what are the things to bear in mind? I'm just going to bring Dorian into this conversation and hear his comments about what he feels the challenges in this kind of a scenario. Dorian?
Hello, Vinit. So fantastic presentation, Ibrahim. Quite excellent. But what I'll do is I'll beg off now because I'm driving at the minute.
Okay,
So,
okay.
I'm listening. Okay, folks, carry on.
Okay.
Right, I won't disturb Dorian because he's joining in while he's driving. I've actually used Sulcoflex lenses, like as I said before, when I've had issues with refractive surprises and myopic surprises in patients, I've used Sulcoflex lens made by Rayner. They are brilliant, and very easy to use. And as you rightly pointed out, the challenges do come with the fact that they can flip over, and if they are mounted, and this is something I tell the junior doctors as well, to look at intraocular lens implants which have an angulation, and it's important to get the angulation right. Otherwise, the outcome from that procedure becomes a bit of a challenge. Patient, interestingly, is happy. So that's an important outcome to look out for. While we do what we do and everything else. So your processes are also important. So the take-home points from this kind of an interesting case is that extracapsular cataract surgery still happens. Post-operative astigmatism, what we call a surgically induced astigmatism, do arise. Most people seem to be comfortable with it and are able to live with it with reading glasses or wear glasses, etc., or contact lenses. Some people don't like it. And those are the ones you have to address the question with, how do you overcome? And as Ronnie pointed out, you liaise with your refractive surgeons as to what other systems in place. One is using your corneal topographer and to identify any other, what we call as undiscovered keratoconus in these kind of patients that can manifest. And also important to find out whether this patient has had a surgical complication, whether we can put a lens implant. And I wouldn't put a Sulcoflex lens in a crowded eye, and whether UBM comes into play. And it's very, very important that all these steps are followed and investigations done before doing the surgery. And under promise, over deliver. And that's the key word I would use in this group of patients. And again, this is teamwork because there are too many challenges. And ideally, these kind of patients, I either have them first in your clinic or last in the clinics because they do need time. And you need to go through that process of explaining to them what are the expectations. They do take a lot of time. So make sure that you're giving yourself enough time to deal with these kind of situations.
Yeah, just to add to that, when you deciding to move with these cases, it's important in the refractive cases that you have stable refraction.
Correct.
So you want to make sure that one refraction is done, and then 3 months later, 6 months later, the refraction is actually the same. And then you can move ahead. Yeah.
That's a very good point, actually, because most refractive surgeons in these kind of challenges say, wait for 3 to 6 months before embarking on the next step. So yes, that is true.
And even with the case before, where we had the refractive surprise, I did the same thing. I waited until I'm sure that everything's stable, and then we move.
Wonderful. I think we would have one more case. I think Ibrahim is going to share with us. This is an interesting challenge, and Ronnie will share possibly a video, probably at the end of it.
Yeah, at the end.
Yeah. Just to tell you all some challenges with these kind of situations.
Yeah, Ibrahim, I actually have the surgery in this one, so I could show it at the end.
Okay, no problem.
Yeah.
Okay, so the second case, a
Any
50-year-old.
comments, any questions, please ask. Don't hesitate. As I said earlier on, this is more a discussion platform. We continue to learn in these discussions.
Okay, so a 50-year-old patient presented with reduced vision in the left eye since cataract surgery was done externally a few weeks ago. So he had cataract surgery done on the 27th of April, and we saw him on the 5th of May, so around a week after the surgery. His unaided visual acuity in the right eye was 20/25, and the left eye was 20/60. His IOPs were within normal range. The right eye was 14, and the left eye was 15. Because he recently did surgery, we decided to do a refraction before he saw the doctor. So the refraction was in the right eye, plus or 50 minus or 50 by 85, with a vision of 20/20. And the left eye was plus or 50 minus 6 by 90 degrees, with a vision of 20/40. When I looked at the eye, I noticed the iris prolapse, so I diagnosed him as surgically induced astigmatism with iris prolapse and sent him to see the doctor. So these were some photos that were taken of the eyes. The left photo, we could see a scleral wound superiorly, and on the right photo, when we told him to look down, we could clearly see the iris was exposed as well as the scleral wound. There were also around 5 sutures above the cornea. On the doctor assessment, he diagnosed the patient as having a PC IOL in the left eye, sclera section with iris prolapse, and high astigmatism induced by sutures. The patient was booked for iris prolapse repair and resuturing of the left scleral wound. The surgery was done. On the first post-op visit, the left eye was healing well, the scleral wound was closed, and the IOL was centered properly in the bag. The plan at this time was refresh, Quidex, and to see the patient in 2 weeks. So these pictures here show the before and after of the surgery. We can clearly see in the after picture that the wound is closed and the iris is not exposed. So after the surgery, the sutures were removed around a month post-op. So we have the refraction before removing the sutures and after removing the sutures. Before removing, the left eye was around plano with a minus 4.25 SIL and was given a vision of 20/25. And after removing the sutures, the left prescription was around plus 0.75 minus 3.75 with a vision of 20/20. So overall, the induced astigmatism decreased by minus 2.25 diopters. We must note that it's not always possible to completely negate the induced astigmatism. This patient went ahead with glasses and is currently doing well. So we basically prescribed the glasses with the minus 3.75 SIL in the left eye, and he was pretty happy. Just for summary, our clinical outline for surgically induced astigmatism, first we would usually try glasses. It must be noted that if the patient have over 4 diopters of cylinder power and anisometropic, they may get trouble adjusting to spectacles. If glasses isn't a good option, we also have contact lenses if patient doesn't want any further surgery. With new technology, we can do soft lenses that can go all the way up to minus 8 diopters in SIL power. So we could try contact lenses, and if the patient still isn't happy, then the doctor would usually consider doing the implantable contact lens. And that's it for the second case.
Yeah.
It's a fascinating case. I'm going to ask Ronnie to share the video first before I embark on a discussion. So just come out of your chat and let him share his video for the benefit of everybody to see, and these kind of challenges can arise as well. So again, this is a patient with extracapsular cataract surgery. Unfortunately, has had a complication. A lot of the cases that we see are doing very well, but sometimes these things do happen. So we just need to bear in mind, how do we deal with this kind of a situation? So I requested Ronnie to show the case, the surgical part of it only, and then we will have a chat.
So this is this surgery for this one. So this is Zared's work. Thanks Zared for doing this amazing video. So this here is the prolapse here, up on top, and this is the wound. Now, there's a few problems in this case, really. One is the wound construction is not as good as we normally see with these cases. So I knew that this was contributing to the SIA, surgically induced astigmatism, as well as the prolapse there. So definitely the wound was an issue in this case. So the first thing I did was I did a paracentesis on the side here to be able to try and get the iris back in, So that's the first thing I did. I just made a little paracentesis. And then the second thing I did, I thought, if it's my lucky day, the myocol, I guess, that I inject would just pull the iris in, So I inject some myocol to just shrink the pupil and see if I could just pull it back in, and with shallowing the AC, dropping the intraocular pressure, the iris will come back in. But well, that didn't work, right? So I decided, well, let me just put a trocar in the back there and reduce the pressure so I could get a little bit of room in the AC. I was struggling for room in the anterior chamber because the AC was a bit shallow. So I just put a trocar in there in the back. And then I decided to do a peritomy to get access to the iris so I could get it back in. So that was the next thing I did. Superior undercutting. And then I use a iris repositor to put the iris back in. And I putting it back in here, and then nicely done. I thought, wow, this is really good, So the iris went back in, and I decided I need a little bit of space, so I put a little bit of spray elastic, and the next thing, the iris come back out. So with a little bit of pressure in the AC, the iris just keep flopping out. So I decided I need to do this, which is take a little bit of the vitreous out. So I do a single port, little limited core vitrectomy, and you'll see how fast this is. And that's it. It really is 5 seconds. And now the AC goes real deep. And I have a really nice deep AC, and surgery is really simple, And I think whoever was doing this surgery before, when they did the cataract surgery, this is what happened to them. They just had a hard eye, and that iris just couldn't go back in, and they were having problems suturing the wound. So it's not that they made a poor section or anything like that. I think this is just in surgery. You have a bit of iris prolapse there. The eye is a little hard. Most of the times it's because some of the fluid that you're infusing in the cataract surgery goes and hydrates the vitreous a bit, and you have a little problem now. You can't get this iris to go back in. So you had to leave it, and it's a problem. And this is one of the ways to solve it.
This is an interesting problem, and what is fascinating about this is we all are aware of problems with the iris. The iris can be atonic. We see that in diabetics. We see that in patients with Flomax. And then, as Ronnie pointed out, in a very shallow anterior chamber or a high hypermetrope, these are challenges. And I know it's easy to show a one-port vitrectomy as we are surgeons, and it's not something that we would recommend for the faint-hearted. But what is important to see out here is that there are ways to deal with this situation. And I think a challenging situation like this, particularly in cases such as angle closure glaucoma, high hypermetropia, a severe diabetic who who's got autonomic neuropathy and whose pupils are all over the place when you're trying to do surgery. And which comes back to a very interesting point, which Ronnie pointed out, is the fact that even the original surgeon found this a problem and they couldn't overcome it. Unfortunately, they tried their best, but it's still the atonic iris was trying to prolapse out and deal with it. And it's interesting that he was hoping that the meiosis or the myocall will sort out the problem, but then it's been there for a little while. It was a very stubborn iris to get back in with just the myocall. So he had to use a situation which was slightly different of using or releasing the vitreous. And I think that worked like magic out here. And one of the other things that we have done in patients is, and these kind of situations, we always call it as preparation of a patient. Besides the wound construction when we do surgery or preparing this patient, I've actually used intravenous mannitol prior to surgery to decompress the vitreous. It hasn't been my first line to use a single port vitrectomy to decompress the core vitreous, which wasn't the thought process, but it seems the most simple way to decompress the vitreous and create room while you're doing surgery in this kind of situations as such.
Well, say that again, how would you do it?
So we would give mannitol. Mannitol would decompress the vitreous, create room, and then go ahead and do surgery.
Yeah.
So that was one of the options that we used to use deal with the situation. So I'll come back to the original problem. So thank you, Ronnie, for sharing that very nice video that you have done and dealt with the situation. I'll get Ibrahim to bring back the Jean Mark has a question, pre-op IOP check.
Let me see.
While good question. It's a very good question as such. It is difficult. I mean,
I would say no. I would say no.
okay.
because I think the problem occurred intra-op, where when you're doing the surgery and you're doing either IA or phaco, sorry, not phaco, but IA, or you're trying to do hydrodissection or something where you're infusing fluid, it's hydrating the vitreous. So it doesn't happen pre-op. Yeah. So it's an intra-op issue.
Correct.
And I suspect if she decided, whoever was doing the surgery, he went back to try and put the iris in, and they did anything like I did, the iris would just prolapse again, or it would hydrate again, the vitreous, which is what was happening to me, you know. So I was glad it came to me in a way, you know. And the truth is, we don't see iris prolapse much at all again, as Franca was asking. And the thing is, it means we are not experts anymore in doing iris prolapse repair, right? So I was glad I actually had a tool here to be able to share it with the guys. And the thing is, what I find very interesting is these iris prolapse cases, if they come in, they would say, okay, let the junior guy handle that, you know, but not recognizing that this is a tough problem, you know, and even the senior would struggle with this one, you know. So it's interesting if you are sent to do this kind of case, you know, and you're not a senior guy. I think it's a tricky one, you know. Just be wary that you know, you should say, hey guy, I think you should do it because I don't do this every day, you know.
But it's a very important question Jean Mark has asked is Dr. Suku, sorry, is the fact that what I have been taught, I don't know what your practice is, Ronnie. I mean, I know what your practice is, but I want to ask you a question. IOP check prior to cataract surgery. I do not like to touch the cornea as much as possible. I want the cornea to be as clean as possible before cataract surgery. So I do not do IOP checks pre-operatively or anything else.
Yeah, but another good question is as Dr. Suku saying here is, if you don't have vitrectomy, which I did there,
yeah,
what are the other options?
Good point.
So yeah. I think, as you were suggesting, yeah, there, you could anticipate that you're going to have hydration,
yes,
and you could do the mannitol.
Correct.
I think mannitol is a very good option.
Very good option, actually.
Yeah. if you don't have mannitol or you don't want to put the patient through mannitol for whatever reason, you could use Diamox.
Very good.
Is another option,
Correct.
you know, and I think those two are two good options to have as you're going forward with this case, you know.
And you're very right about it, that the other thing I would do also from a surgery point, it's pre-operative assessment, and being aware of this kind of a situation and using the right kind of viscoelastic and also your wound construction. This can happen with phaco as well. I mean, we've all faced an odd situation where the iris wants to keep popping out, and you find that there is traumatic iris changes post-operatively. Not that it doesn't happen, wound construction. And one of the areas where I have seen this problem, where the patient does not have diabetes, has got no shallow AC, is your paracenteses are very, very wide, and there's a lot of wound gushing out, and then brings out the tissues. So iris prolapse can happen even during your normal routine cataract surgery. And it's important to pay attention to your wound construction when you do your main wound and your paracentesis. So it's important whether you do bimanual IA, coaxial IA, etc. So that's a very interesting thing for me. So I'm going to ask Ibrahim to bring that surgical induced astigmatism, because that is a very complex subject. Ibrahim, just bringing surgical induced astigmatism. So why this is interesting for me is the fact that a lot of people don't pay attention to surgical induced astigmatism, because you have a lot of patients who are comfortable with surgical induced astigmatism, correctable with glasses, and people who have had glasses before live with the glasses and they don't do anything. So Ronnie, coming back to your question on you, when you deal with the situation of surgical induced astigmatism, what is your thought process behind managing a patient with surgical induced astigmatism?
The thing with in this particular case, right? When I
forget about this case, surgical induced astigmatism.
Well,
generally, give me a theme.
Let me do this one, right? And then I could go jump. But this case is unique here because you have three things here. You know, when I saw this patient, I thought, hey, we have three problems here. We have three things causing SIA. You have the wound. So I wasn't sure about the wound construction at the time. You have the sutures. And you have the iris prolapse. So what I thought, I say, here, what guy? This is going to take me 6 months to correct. Yeah, because the first thing I had to do is, and I had to do multiple surgery for you. The first thing I had to do is correct the prolapse. So I was already thinking the prolapse will correct a few diopters. I was thinking if I remove the sutures, it will correct a few diopters. And then I was thinking I needed a sulcoflex, like, to correct the rest. You understand? So I already was figuring it out, and I telling this guy I would need to do a few surgeries for you. And after about 6 months, I might do the last one, because I already think in my head, I need time to sort this guy out. You know, minimum 6 months, more like a year. So in the first consultation, this is how I was talking then. I say, you know, you have a problem. I have the answer. You know, I think I could solve it, but it's going to take a little bit of effort. So I don't want you worried here. Because he was worried because his eye was red, painful, and he can't see. You know, so I was telling him I could definitely get your pain sorted out, because when I do the iris prolapse, I knew that would help. And I could improve your vision because I'd reduce your astigmatism when I start working with you. And I'll give you a lot of Pred Forte, you know, reduce the inflammation. So I already knew I could get this guy happy to some extent. So that was my thought process with this particular SIA case. But the one before is interesting because that was just a cut. Nothing else was really going on in that one. And all we needed to think was this sulcoflex lens. So I think every case of SIA is different. And every case has to be judged and assessed on its own issues and problems inducing the SIA. And then we figure out what is the best option. So I think this guy that we're looking at here, this particular guy, will need a sulcoflex lens in the end, because he is going to come back to me and say, you know, this glasses is a little bit of a problem. I don't like it, you know, because he never really was aware of glasses before. And then we may have to think about doing the topography, the UBM, all the tests now, set up and try and do the sulcoflex lens for him. So that's how I think.
So that's a good point that you have commented about. One is deal with the acute situation first. And every patient, as you rightly pointed out, has to be dealt on the individual merits. So identification of the issue, discuss the pros and cons, which is what you have spoken about. And then looking at what Ibrahim given us is work with your team, like the optometrist out here, and discuss contact lenses, soft contact lenses. And it's useful to know what are the options and what is the range of options that are available. And then try and see if we can minimize surgery as much as possible, because these things become a little more challenging and unpredictable. So for me, each case has its own merit, and it needs to be dealt on a very, very, again, individual basis with all the investigations. And again, I point out to you all that these cases are not easy and straightforward. They are complex, they need time, your time, and the patient's time, and they go through a process of recovery. And as Ronnie pointed out, sometimes these things take about 6 months to resolve the matter. So bear that in mind, inform the patient, inform the family that they may not have excellent eyesight for about 6 months' time. I think we've just got a few more minutes before we wrap up today's session. What I want to know is any more questions coming out from the audience, from the participants, etc. Any questions from Ibrahim or Rinel that they would like to pose us at this point of time, while we are looking forward to any more questions that might come up. But what is interesting is cataract surgery, I just go back to what I said earlier on, has become and has moved on to becoming a refractive procedure. It's a once in a lifetime opportunity for these patients. One right eye, one left eye. A lot of preparatory or pre-operative planning for that individual eye, looking at the comorbidities that exist. Very important, the processes that you have in prior doing cataract surgery, such as biometry, identifying if the patient is diabetic or Flomax or any other iris problems that you might find as challenges in your intraocular surgery is important to identify. And during surgery, forewarning your team, well, this is a complex patient, it will take a little bit of time, so on and things, and having the tools that you might require to handle this situation is important. And preparing yourself as a surgeon while dealing with these complex cases, making sure that your state of mind is very present. And these are important for you all to be aware of. And then once you've done all these things, don't forget, from a clinical governance point of view, auditing your outcomes, looking at your processes, learning from them, and taking home what's working well. Remember, we spoke about biometry challenges. And let me tell you, biometry predictability is excellent for about 98% of the time. So that's kudos to the team. 98, 99% of the time, your biometries are absolutely spot on with the outcomes that we get. So 1% of the time, as with any procedures, there are some challenges. We need to learn to mitigate that as we go along. So those are my comments. And I'll just ask Ronnie to give me his comments if he has any before we wrap up the session.
Well, I'd just like to thank everybody for participating. And we had a nice chat here going, and also some input from some of the other docs. This is our first time doing it. So really, I think it will grow with time, and then we'll have more stuff. We have a lot more cases that we could present. I had to stop Rinel. She's so excited to present all her stuff. And I was hoping to have about 3 sessions before the end of the year on cataract. So I think there's more to look forward to going forward. And I'd like to thank our optometrist Ibrahim and Rinel for putting together all this work, because there's a lot of work to try to get these presentations ready. and Ibrahim, because I only told them last week
Yeah.
to put these cases together. So this is well done from Ibrahim. And me and Renelle have been working really hard on doing Hato for quite some time, and I really enjoyed all of that. So thank you to my team for doing all this work, and thanks, Vineet. You know, we always call on you, and we don't share much of the information, and somehow you seem to be able to wing it every time. So thank you so much for taking up the mantle, for teaching, and everything going forward.
Wonderful, wonderful. And then I would like to thank Anura and the team for doing all the background work and helping us out. Anura, this time I haven't forgotten to thank you and the public forum and for everybody to participate. But also we would like to know what kind of teams that you would like to have this forum being used for. And if anybody is interested in presenting their own cases, just message me or Anura so that I'm aware of it. I work with you all so that you all can come and share. And this is a forum, I want to tell you all, is an open forum. It's not about criticizing anybody. We all continue to learn, and we want to use this platform for learning process. And that's the most important thing I want to open this forum out for. So have a good evening, enjoy yourselves, and take care.
Thanks, everybody. Anybody have any questions? We didn't ask that.
We did, but
Okay.
everybody is busy preparing for their dinner.
Okay.
I think they have other things to do. But I'm quite sure y'all can feel free to, there is the ophthalmic trainees group, and Zared oversees the cases out there. So if y'all are not participating in that group, please feel free to join in that group and join discussions. And as I said again and again and again, the more cases that you bring to the forum, we will all be learning together. So please feel free and share. Anybody has any comments? I know Dorian is driving, so I don't want to disturb him. Anybody else has any comments that they want to share? Okay.
No. Okay,
Take
thanks
care.
very
All the
much.
best.
Have a good night, guys.
Bye-bye.